Yeah, this week, what we can do is I can ask Imad to, if you want, we can arrange a time and we can have a half an hour discussion regarding how we want to go in future.
Right.
Because really we need to start because we are dot on time. But I think if you just write to Imad when you want it, he will arrange it and we all can get together whatever time suits you. Okay.
But how often we are going to meet? 2 times a month or every weekend?
Yeah, twice a month is what we decided. This is the only time we are taking exception because this was already decided from beforehand. That was the reason. Otherwise, every 2 weeks.
Yeah. Okay.
Okay, but we can meet up in next few days whenever Pepe, Henry, and all of you want it. You can decide and let us know. So we're going to start. It's really my pleasure to welcome you all in this webinar by IFNE and WFNS Endoscopy Committee. It's a joint session. And it's really my honor and pleasure to see such august people sitting in the audience. And on top of it, we have got 2 of the world's top endoscopic surgeons here with us. We're going to start with Giuseppe Cinalli, who was a past president of IFNE and is a very big name in the world of neurosurgery. So Pepe, without delay, we'd ask you to start your session. So you have your talk, and then we have a discussion and MCQs for Pepe, and followed by our dear friend Daniel Prevedello from US. He's been very kind to give us this time. Okay, let's start.
Thank you very much, Salman. Hello, everybody. It's a great honor and pleasure to be here with you. I have no disclosure, and we are going to talk about the endoscopic management of intraventricular tumors. We all know the limitations of traditional endoscopy in intraventricular tumor removal: the small working channel, a small forceps, long and boring procedure, blurring of vision during endoscopic procedure, and usually the indication was limited to tumor of less than 1.5 to 2 centimeters in diameter. Okay, advancing. For example, many years ago, for example, in this case of almost 14 years ago, we had this boy of 14 years. You said it's a very, very limited and floating tumor inside the third ventricle with a very slow evolution over years. And this is the way we dealt with that at that time, when technology was not so advanced as it is today. You see that the tumor is floating, is moving inside the foramen of Monroe. A big forceps allowed big pieces of tumor to be removed, but finally, after 2 or 3 bites of forceps to take biopsies, you start to have blurring of the vision and blood obstructing the vision and limiting the possibility to work. And finally, the big pieces that are apparently removed, in fact, were very small. So after a few minutes, we started to have this kind of vision, and we could only manage the stuff by inserting an aspirating cannula inside the third ventricle to remove the tumor with this aspirating cannula, traditional aspirating cannula, then not going through the working channel of the tumor. So certainly the result was very good, but certainly technologically things could have been much better. In the next step, certainly, and we had significant step forward with the use of ultrasonic aspirator dedicated to endoscopic procedure. It's a device that can fit only through a GAB endoscope into the working channel of a GAD endoscope. It has been described almost 10 years ago by Ertel, Krauss, and Gab. They started to have experimental experience on pig's brain, and they had very limited clinical experience on intracerebral and intraventricular hemorrhage, but finally it was used very, very few times, and the diffusion was very slow and very limited, even by their own authors and early describers. So we started to have the first impact with this technology in 2013, and in the first 4 years of our activity, we operated on 17 cases, 10 intraventricular, 3 paraventricular, and 4 suprasellar. Histology of these cases now, it's a little bit larger, this experience, but the early histology were 3 SEGA and tuberous sclerosis, 2 optic pathoid glioma, 6 glial tumors, 2 craniopharyngiomas, and 4 miscellaneous. Surgical approach was in 15 cases precoronal, in 1 case parieto-occipital, and in 1 case frontal anterior. The surgical technique, there are a few things to remember using this device. We have to perform our surgery under continuous irrigation with a warm ringer lactate, because this is a sucking device, and the CSF that is sucked during the procedure must be continuously and actively replaced by warm ringer lactate. We have to keep the aspiration power relatively low, 15–20% of the power of the machine, because it is largely enough for any kind of tumor, and we limit the risk of excessive intraventricular negative pressure and excessive CSF removal. Cavitation instead can be adapted to the tissue, ranging from 20 to 80%, but we even adopt 100% of the power in craniopharyngioma and in calcified tumor. And what is most important also is a direct control of the suction tube with the possibility of immediate clamping. One of your assistants must deal with only possibility of clamping of the aspiration tube in order to avoid a sudden risk of aspirating a big vein or a big vessel inside the suction device. This is the GAB endoscope with the ultrasonic aspirator here on the top. You see it's very long, and it fits through the working channel of the GAB endoscope. This is the way it is assembled. You can see it can be held like a gun. This is the way we do through a standard coronal bar hole. We introduce our cannula under navigation control. We remove the stylet. We insert the optic. All the endoscopy held by the pneumatic holder. Now we are inserting the ultrasonic aspirator inside the working channel, and we adapt our surgery. This is the suction tube that is closed, and here this is the way we remove. This case was a SEGA in a case of tuberous sclerosis. In case of tumors of the third ventricle, how do we do? For example, in this case, this is a tough case because it was very easy, apparently because of the very, very large ventricle, very large working chambers that we can deal, and the tumor was bulging inside the lateral ventricle through the foramen Monro. And in this case, we can see that unfortunately there was a very strongly calcified core at the CT scan. So we tried just to see how things could have been done, but we had very many doubts about the possibility of doing this case completely endoscopically. This is the way it presented after entry into the lateral ventricle. The tumor is bulging into the lateral ventricle. This part that is bulging inside the lateral ventricle was in fact very easy to do with this machine. The tumor was relatively friable, not very bleeding. As you can see, the CSF remains very, very clear. You can dissect the tumor from the edges of the foramen Monro, limiting the possibility of choroid plexus to be aspirated. Stay away from the choroid plexus if possible, or coagulate it before going too close to it. The part that is bulging, you see that is just to show how easy and how excellent is the vision when using this device, because all the blood is sucked by the aspirating device. But when you enter into the third ventricle with the calcified core, you see that you can see the calcium crystals, and then you have to work much closer to the tumor. You see the calcification. We have to increase your power of fragmentation and of aspiration, but working very closely to the tumor, you can really check very well the quality of your removal. You can avoid to enter into normal tissue, and with continuous aspiration, you have an excellent view until the very end of the procedure. And in this case, you can see that we have been able to remove all the tumor that was adherent to the floor of the fourth ventricle without injury. There is maybe some small remnant at the level of the internal cerebral vein, just below the internal cerebral vein, but finally this remnant remains stable. This was a pilocytic astrocytoma, and this remnant remains stable now at 5-year follow-up. And this is the post-operative CT scan. You see that completely remove even the calcified core inside the third ventricle. This was our first large case, a paraventricular tumor coming from the white matter that was close to the corticospinal tract. For in these cases, we decided to do before an endoscopic biopsy, because we had a very limited possibility of working through the interhemispheric fissure through a transcallosal approach or through a transparenchymal. That was really not a good idea in this case. So we started by doing an endoscopic biopsy, and we fall into a tumor that was an ideal target for endoscopic removal, because it was very friable, very soft, very, very small hemorrhage, very few vessels. So we were, after doing the biopsy, we introduced our endoscopic ultrasonic aspirator inside the ventricle, and we were able to aspirate and fragmentate slowly but effectively and progressively all the part that was bulging inside the tumor. You see that it's very, very easy. You can recognize very nicely the tumor from the ependyma. Under continuous irrigation, you see that you can avoid the ventricular collapse. So you can work in a chamber that remains quite well dilated. You see that this is the upper part of the tumor. This is the upper part of the tumor that is removed, and we can push our tumor removal until the all the part to remove all the part that is bulging inside the lateral ventricle. Then after this first procedure, the histology came as a low-grade glioneural tumor. So we did a second endoscopic procedure through the same hole to remove it completely. And finally, in two procedure, we were able to remove almost completely the tumor, except a small infiltration area close to the corticospinal tract. This is another case of tumor that is bulging from the third into the lateral ventricle. This was also intraventricular ganglioglioma, and after endoscopic biopsy, after endoscopic removal with the catheter, you see that the tumor is completely removed. We did also a septostomy, and the tumor was completely removed. So for tumors of the region of Monroe, also, for example, in tuberous sclerosis, the SEGA tumor are a very nice target for this kind of surgery. You see, in this case, we had the right tumor that was growing, so there was an indication for this right SEGA. With ventricle that were absolutely normal, normal size. So we used the navigation to enter inside the ventricle, and we were able to work with some difficulty in the earliest minutes, because the chamber of work was really very small, and there was a significant collapse of the chamber during the aspiration. But finally, we were able to create our surgical cavity. We were able to remove, this is the most posterior pole of the tumor that is bulging inside the trigon. You see that the tumor is a little bit harder if compared to pilocytic astrocytoma. And this is the way we dealt with the thalamus striate vein. We were very worried about the possible infiltration, but here you can see that the cavitron is able to dissect the tumor from the thalamus striate vein that you can see here, and we were able to remove completely the tumor that was adherent to this. Now we cut the tumor in two parts, and we can see from the foramen of Monroe to the ventricular trigon. And here we are removing the very, very last part that has been completely excluded by vascularization. So it's a completely non-bleeding area of the tumor, and we are able to remove completely the tumor from the region of the foramen of Monroe, and with a very nice postoperative result. Here you can see that the right part has been completely removed. So excellent indication also for SEGA in tuberous sclerosis when there is an indication. For craniopharyngiomas also, when we have a craniopharyngioma with a huge cyst inside the third ventricle, even if there is some part that is infiltrating the hypothalamus, we can deal with an intraventricular approach in these cases. And this is the MRI before surgery. The cyst is occluding the ventricles, and the left ventricle is larger. Just applying the suction of the cavitron on the cyst, we can aspirate completely the liquid content without any spillage of motor oil fluid inside the ventricle. The vision remained very nice during surgery. Here you can see the limit between the infiltration of the tumor and the hypothalamus. We avoid to touch the ependymal hypothalamus, of course. This is the posterior part. We are inside the third ventricle. This is a posterior part of the tumor that is dissected free from the floor of the third. Here you can see the mammillary bodies, and you can see that with a normal, almost normal vision with very clear CSF. And this is the postoperative CT scan and MRI. You see that the MRI apparently is very nice. There is some residual calcification at the hypothalamic level, and were treated by radiotherapy. This is the pre-op, and this is the post-op. And other cases of craniopharyngioma, for example, this looks like a tough case because of the huge cyst and the significant solid component at the hypothalamic level. But finally, even in this case, as you can see, with a very nice vision, just applying the ultrasonic aspirator, we just can suck out completely without any spillage into the ventricle the motor oil content of the craniopharyngioma cyst. We can fragmentate the wall of the cyst very nicely. We can avoid and limit the injury to the hypothalamic wall. But in this case, the tumor was relatively easy to dissect from the hypothalamus. So we were able to aspirate completely the cyst from the third ventricle really very nicely, because it was relatively easy to dissect, and even the solid part was possible to remove completely. And at the end of the surgery, this is the post-operative MRI. We had a complete removal of the tumor with a 3-year tumor-free follow-up, and this is the post-operative MRI. This is the pre-op, and this is the post-op in craniopharyngiomas. For optic pathways gliomas also, when the child is very small, the tumor is very big, and these patients are mainly candidates to chemotherapy in a first attempt when they are below 5 years of age. But then you need to manage the possible ventricular dilatation, and you need histological biopsy. So in these cases, we just do an extended biopsy of the tumor, entering through the lateral ventricle with the neuronavigation that is mandatory when ventricles are normal. We aspirate the tumor through the foramen of Monro. We go to the posterior part of the tumor, aspirating the most posterior part in order to create a free flow of CSF between the foramen of Monro and the Sylvian aqueduct. You can see here that the pilocytic astrocytoma of the optic pathways are excellent candidates for this kind of surgery. The vascularization can be quite strong, but you can manage this with a good aspiration of the ultrasonic aspirator. Then we enter here into the third ventricle. This is the massa intermedia, and you can see that removing slowly the posterior part of the tumor, you end up in the posterior third ventricle, and we manage to have a very clear vision of the aqueduct and of the posterior part of the third ventricle to be sure that the CSF can flow freely. You see here the posterior part of the third, and this is the aqueduct that is being completely set free from tumor occluding it. This is the preoperative MRI, and this is the post-op. You see that the upper part of the tumor has been removed with a very nice flow from the both foramen of Monro and the aqueduct of Sylvius. But you can also do more large removal, like in this case, with a partial removal that is well below the 50% of removal in this case, another case of optic pathways gliomas. Another case, these optic pathways gliomas and the pilocytic astrocytoma also bulging inside the third ventricle. You see that there is a very significant volumetric removal of the tumor, and the residual tumor infiltrating the optic chiasm was treated by radiotherapy. There are alternatives to ultrasonic aspirator. The Nycomyriad, that is not yet available in Europe until a few months ago, maybe a couple of months ago, we started to have also Nycomyriad in Europe, but it's mainly a US device with very nice initial experience in some team in the United States. It's a mechanical way of cutting and aspirating with a guillotine mechanism. And this is a video taken from YouTube. You see that there is a lateral opening with a guillotine and the aspirating device. So the tissue is aspirated inside the hole, and the guillotine cuts progressively all the membrane and all the tissue that is inside the lumen of this cutting device. And it's the early experience also is not bad in the United States. We can use this kind of ultrasonic aspirator going back to the ultrasonic aspirator, also in the case of cyst progression follow radiotherapy, for example, in this case of optic pathways glioma, worsening visual acuity, it was decided to open the cyst because the only variation in this tumor after radiotherapy was the enlargement of the cyst. And in the case of cyst enlargement, this is not a tumor progression, so you just have to deal with with the cyst progression, and you can fenestrate the cyst of the tumor inside the ventricle in order to keep a large communication between the cyst and the lateral ventricle. In this case, it looks as if we are entering the hypothalamus. In fact, we are just working inside the tumor, and we are able, working inside the tumor, to remove some part of the tumor and open largely the cystic cavity. You see here in the depth the cystic cavity that appears. This is the cyst, and by doing this, we are able to create a very nice communication between the cyst and the ventricle and limiting the progression of the cyst. This is the pre-op and this is the post-op. You can see that the cyst is now completely deflated, less mass effect on the fornix. Another pre and post-operative comparison of the same patient, and another pre and post-operative comparison. This is not a case, of course, that is candidate to endoscopic removal. It's a huge, giant neonatal anaplastic ependymoma. It required 3 microscopic procedures in order to achieve a satisfactory tumor removal because of the huge size and of extreme bleeding in a very, very small babies. But after 3 surgeries, microsurgical procedure, we still have this wall of the cyst that is not visible through the transfrontal approach of the other side. And so we decided to, since it was a blind spot for the microscope, we decided to use an endoscope in order to achieve a good vision of this. And in this case, we were able to remove only a very, very small part at the beginning because the tumor was so bleeding, even in a very large cavity. Look, only after a few seconds of manipulation, the bleeding was so intensive that the vision was completely blurred. And so we decided to use the dry field technique, described by Gab several years ago, removing all the CSF and working in the air environment. You can see the complete and easy removal of the tumor that is infiltrating the ependyma of the other side. You can see that the quality of vision remains very nice, even if there is some foggy you have to deal with, but the quality of vision remains nice. The blood is not contaminating any CSF, and you can remove nicely all the tumor that is infiltrating the ventricular wall of the other side of this small baby. That in this case, we were able to avoid the 4th microscopic procedure and the 4th craniotomy in this baby. And you can see that in the post-operative MRI, we really have a very, very nice removal. We were able to check all the circumference of the frontal lobe of the other side, and it was a very, very nice final removal. So our early results until 3 years ago were 9 complete removal, 6 planned partial removal, and 2 enlarged biopsy. The procedure was certainly easier in larger ventricle, but possible in normal ventricles under navigation control and continuous irrigation. Strict control of aspiration power, of course, is of utmost importance. The complications were 1 subdural hygroma treated by subduroperitoneal shunt. So in conclusion, the patients harboring intraventricular tumors are in most cases ideal candidates for endoscopic biopsy resection. Endoscopic cavitron is very effective in selected indications. Potential to expand indication to pure endoscopic resection. And finally, specific training, of course, is necessary. This is not a very easy surgery, and you are dealing with a sucking device inside the ventricle. So you really have to be trained to do this on phantoms and on anatomical or animal models before starting doing that on a patient. Thank you very much.
Excellent, Pepe. It was an amazing talk. I think you took us through thick and thin of ventricular anatomy, and details were superb. You know, just like your typical talk. There are a few questions that are here for you, and we'd start with the first question. By using the NICO, do you destroy the histological structure of the tumor? Is it possible to get good pathological outcome from there, or are the pathologists in trouble because of NICO?
I have no personal experience with NICO. I only tested it in the booth during congresses. But I think that in every device it is possible to collect what you aspirate. So I think there is no problem with histology. As we do with the endoscopic surgical aspirator, we send all the collected items to the pathology. I think in the same way I can do with NICO myriad, but I have no personal experience.
Okay, there is a question from.
Do you mind if I say something about that? Because I have experience with that.
Sure.
Yeah, it's it does have a pouch. There are two things actually. There is like a bag that with a net that collects the material with the NICO myriad, and also there is a device that they created recently that the specimen goes into this chamber with cold environment for if there's any intention to send to a lab to produce to do research with the cells even, like, so they have this nice device there. The only thing I would like to talk about the NICO, that anyone in the room, if you one day if you're going to use it, it's very powerful suction. So you have to start very low and then start going up as you need. If you start with a very high, it can really cause a problem. So, you know, I discovered this in a first time I used. I actually was using for a third ventriculostomy, and I had a very redundant floor of the third ventricle, and I didn't know better. I have my aspiration the same way I do endonasal cases, so I have in the maximum, and the entire floor was aspirated at once, like, and it disappeared. So I was lucky. There was no other problem, but you should start very low in their settings.
The same with us. The same with us. We also have some experience in the usage of ultrasound aspiration in the tumors of the third ventricle, and I agree that the main thing is the balance between the suction and irrigation. This is a very powerful instrument to take off the bleeding, but on the other hand, it is very dangerous if you cannot maintain this balance. So it's my remark, and my congratulations to Giuseppe with an excellent surgery shown to us. Thank you.
Pepe, there's another question regarding, you know, a lateral ventricular tumor. How do you decide which side you're going to come from, ipsilateral or contralateral? So one of the residents is asking this.
It's mainly based on the size of the foramen Monroe. Fortunately, in these cases, usually the ventricular dilatation is asymmetric. So you are a little bit forced to choose the larger side. But one thing I would like to say is that even when you have normal ventricle and you have a small size ventricle that are perfectly symmetric, of course, I prefer to choose the non-dominant side, so mainly the right side. And this is possible to do even in normal ventricles. Large ventricle help, but the small ventricle are not the contraindication. This was shown very nicely by the group of Sweden with the paper of 7 years ago. But experience now is very, very nice with this. And I have many, many cases of biopsy and tumor removal in normal ventricle. You need training. Certainly you need training. This is not for beginners, but you can really do very nice things even in normal ventricles.
Okay, one of the trainees have just said that they would like to have another talk by you for trainees with going slow and showing the anatomy and showing small tricks, because you were teaching the masters, and the guys who are out there, majority are not masters. So they've requested that you should give another talk later on at some stage, going slow and going through the anatomy at the same time.
This is a very nice idea. I think we should differentiate webinars for experts and for beginners. Absolutely. I'm sorry if I was too fast. That was IFNE webinar, so I tailored the presentation on neuroendoscopy experts. But of course, I'm ready to do every other kind of more basic and slower presentation. With pleasure.
And complications of dry field technique?
Personally, I only had to use 3 times. it is already a technique that you use when you have a complication. So you should try to avoid complication of a complication dealing. So, but the main complication is in one episode, I had the feeling that my ventricular chamber was decreasing in size. So I stopped immediately my aspiration and I refilled rapidly the ventricle because I really had the feeling that some subdural collection was going to be to appear. Finally, the post-operative CT scan was perfect and I could continue the procedure without any problem. But the main risk is this. The main risk is a collapse of the cortical mantle if you create a too negative pressure inside the ventricle.
Mohammed has a question. He's asking, how long does it take for these surgeries if you're taking small piecemeal with your Cavitron aspirator?
You know, as a general rule, it does not come from me, comes from Christian Centros, who was my master in practice. He was saying, whatever you cannot do in 2 hours is not worth to be done, and you have to open the ventricle. So I basically, my personal limit is that in intraventricular endoscopic surgery within a fluid environment, after 1.5 hours, you lose concentration and you take too many risks, I think. So but the average of our tumor removal surgery was 1 hour, 1 hour 15. So it's largely within the limit of this. And
there's a question from another trainee, is that how do you know beforehand if this tumor is going to be vascular or not?
Some tumor can give to you some clue on the MRI, but basically there is no way. You, in one case, I remember of a pilocytic astrocytoma of the third ventricle. I was very happy of entering into a very easy pilocytic astrocytoma. That was a real hell. It was a pilocytic astrocytoma, but it was incredibly vascularized, and it took really a lot of time, a lot of fight. So it's not very easy to predict.
So another question is, when do you perform ETV after removing tumor?
After removing tumor, this is a very important topic when you are dealing with the tumors of the posterior third ventricle and in the pineal region. In the tumors of the Monro foramen, bilateral Monro foramen, I always do septostomy during the procedure, because to help circulation immediately after surgery and to avoid the risks of blockage of a single foramen or Monro. Third ventriculostomy in tumors of the third ventricle of the anterior third, normally they come from the hypothalamus, so there is no indication to ETV, basically.
Okay, Henry, have you got any comments? Sergey?
Yeah, Pepe, thank you for this nice presentation. I have one question regarding the patient with the optic pathway glioma, where you had radiation and afterwards visual disturbances, and you fenestrate the cyst. Did the vision improve after this procedure?
Yes, there was a dramatic improvement. In our experience, when you do only pediatric neurosurgery, this is a kind of situation that you have to deal with at least once in a year. It's not a tumor progression. It's just a cyst enlargement after radiotherapy. It's not an indicator of neoplastic progression, but you have to deal with the compression given by the cyst. And in patients who already have significant trouble in vision, already long-term compression and radiotherapy on the optic chiasm, even small enlargement of the cyst can create a significant drop in visual acuity. Fenestration of the cyst is the best way to deal with this.
Okay.
You have an excellent result.
One comment regarding the Myriad. This is probably a nice device for certain indications, but the price is over $3,000, at least some years ago when I asked for it. And there is a single-use device. So I think in Germany, we will never use it. I think the same would be in Italy. It's too expensive.
I agree. I think that when they came a few months ago to introduce this device in Italy, it was not that expensive, I think. I even managed to have some devices available for the workshop in January, but of course with the COVID everything jumped, and so we will know we will know the next edition of the workshop.
Okay,
Yeah.
Adrian has a question. Adrian, go on.
Hello, everyone. Pepe, I have a question. What happens with the accuracy of endoscopic biopsies whenever things are, aspirated ultrasonically? How good is the path report? Perhaps you take previously a sample with the traditional endoscope,
Always.
but tell us how do you do it?
I always take a sample before the use of the cavitron, but it is demonstrated since many years that the tissue sample that you get with the standard CUSA XL has the same value as the piece that you collect with the normal stuff, especially when you are dealing with the genetic sampling and genetic profiling. It is exactly the same value. So I take some small bites, but the amount of tissue they can get with the endoscopic aspirator is excellent, and they are very grateful for this, the pathologists.
Thank you.
Okay, there's a question from YouTube. There are about 25 people connected via YouTube. We have 300 over here. So that's going live on YouTube. So the question is from Adnan Khalek, who's asking, how do you manage cases with monoventricular hydrocephalus?
There were a few cases in my presentation before. You usually approach the tumor through the largest ventricle, and at the beginning of the procedure, I do a septostomy, because with all the significant amount of fluid that you are using, and with the negative pressure that you apply when you are sucking tumor from the lateral ventricle, you need to have the best possible communication between the right side and the left side. So before starting to do this kind of surgery in an isolated lateral ventricle, you need to do septostomy.
Okay, any more comments before we move on? Okay, I think it's time to move on. Henry, would you like to introduce Denny, please, so we move on?
Yeah. So a great pleasure to welcome you, Danny, here in the IFNE joint webinar from IFNE and WFNS Neuroendoscopy Committee. Great pleasure to have you here. I think everybody knows Danny already. He worked a long years ago together with Amin Kassem, and they really pushed forward the endonasal endoscopic surgery, especially expanded approaches. And we are very happy to have you here. And today you talk about pituitary cases, which might for you only a minor surgery, Daniel, right?
No, we'll actually today talk about the anterior skull-based meningiomas.
Oh, then you changed topic.
No. That the confusion is that I'm also giving a talk on Monday, which is the pituitary.
All right. Anyhow, any topic is welcome.
Yeah, no, I appreciate. Well, thanks so much. It's really an honor, a privilege to be here. When was it, like 1 or 2 weeks ago that I had the honor to watch the entire presentation. I got a message in my email, and I saw that you guys were doing this. I was not aware, and it was great and well done. And then and thank you then for inviting me to be here. So it's really great to participate. And I didn't know you have also a YouTube channel broadcasting live this, so it's really great. So I'm gonna go ahead and share my screen here and start. Let's see, let me open it up again. Wait a second.
It takes just a few seconds to come up.
Yeah. Are you guys seeing that okay?
Yeah, perfect.
Yeah, so as I was saying, the idea for today is I'm going to try to share basically our philosophy on doing surgery for anterior skull-based meningiomas. I think this is it's a polemic and controversial topic because, as you can see, different neurosurgeons will have different opinions with this. I don't think this is something that has matured completely in terms of indications. There's some surgeons that have been published on endonasal over the years, and then they switch to craniotomy. There's all different flavors, you know, and I will show over the years, I also changed some of the way I take care of the patients with anterior fossa meningiomas, and I'll try to show you here how we do this. So when we decided to go endonasal for meningiomas of the anterior skull base, we are basically following the principles of skull base. And the idea is to get to the tumor that is in the bottom of the skull, making the resection with less retraction on the brain possible. I think that's one of the principles that the endonasal allows you to do, because you drop this angle very low, so you deal with the anatomy of the skull base first, and then you get to the tumor without retracting the brain or manipulating the brain. We transform this in a cavity, so you can work through the sinonasal cavity, always with bimanual technique. I think this is something that nowadays is not an issue, but when the endonasal endoscopic surgery started, like some surgeons tried to work with only one hand, and that was a problem. So when I perform endonasal surgery these days, it's really like two-hand technique. For me, it feels the same type of technique when I am in the microscope. And we do this as with the teamwork with the ENT colleagues as well. So the way I like to show in terms of advantage of coming endonasal is the fact that we transform a skull-based surgery into resection of a convexity tumor. Because if you look at this imaging, when we come from below, it's really like a convexity tumor. We take the vascularization first to debulk the tumor, and then we can go around and peel the tumor eventually from the brain, and exactly like we do with the convexity meningioma. And it's very important to have that devascularization of the tumor early on. So for a tumor like this, the anterior and posterior ethmoidal artery is very important to take them out and devascularize the tumor very early. Of course, if it moves more posteriorly, it will be different type of vascularization, and we'll try to show that as we present this talk. And for small tumors, it's still possible to get a Simpson 1 resection when we perform an endonasal approach, versus if you come with a craniotomy, most of the time you will go at the dura, bipolar the dura at the end of the procedure, but not really resect the dura, and sometimes even the hyperostosis that can be present in the bone underneath. And by coming endonasal, you actually take the hyperostosis earlier in the case. And for small tumors, you can actually get a more complete resection. One of the downsides over the years, we've been discussing this, is the risk of CSF leak in these cases. And it was in 2006 that with the group in Argentina, with Dr. Haddad, that they came up with the flap. And the flap has been the main reconstruction that over the years that has been helping us to continue this type of technique where we come endonasal and resect these tumors. Still, for meningiomas, I'll tell you right now, I still quote for the patients 1 in 10. I'd still give the patient the chance of 1 in 10 to go back to the operating room because of a CSF leak, around 10%. That's I try not to minimize that, because you know that's something that it can still happen and is a reality. So recently, I'm going to start with tuberculum cell meningiomas and go more like anterior, go from posterior to anterior on the skull base. And I want to show this work from here the group from Naples with San Francisco. They published on a classification of tuberculum cell meningiomas. This has been very interesting. I can start looking at this. Basically, you give scores for different aspects. So you give a tumor score in terms of size. 17 millimeters, get 1 point if it's less than that. If it's 2 points, if it's more than 17 millimeters. If it invades the canal, no canal invasion, it gets 0, unilateral 1 point, and 2 points if it goes to both canals. And in terms of arteries, 0 points if just touches the arteries. If it goes 180 on the artery, get 1 point. And if it goes surrounding the arteries of the anterior circulation, then it gets 2 points. So then basically you end up with if 1 to 6 scores on the tuberculum cell meningiomas. And so you look at a case like this kind of gets around score 5, just to put it in perspective. And I still will do these cases with an endonasal approach. I think that one of the main advantages of coming endonasal for these tumors is the fact that you can see the undersurface of the optic nerves bilaterally. When you come with a craniotomy, we can discuss this later. I know this is controversial, but I feel always more difficulty under the optic nerve in the ipsilateral side of my approach. So I feel that endonasal, I get a better resection. Other advantage on tuberculum meningomas is that we devascularize the meconial arteries by coming endonasal very early here, because by taking that blood supply of the tumor there. So I'm going to show some examples, and this is the way it looks like after we take it out through the nostril. And I like to always call attention to the importance of an MRI post-op showing the enhancement of the flap, fulfilling and completing the reconstruction. And the other thing is the enhancement of the pituitary gland itself, because that shows that you preserved the superior hypophyseal arteries, and you see the blood supply of the pituitary gland is still intact. Many papers over the years have been publishing the main advantage of coming endonasal for the tuberculum meningioma is really the vision preservation. So the vision outcomes overall in the literature, in meta-analysis, they show the advantage, possibly because less manipulation, particularly under the ipsilateral optic nerve, that you don't need to move the optic nerve to see the disease down there. But I understand that that's still controversial. I've done, I don't know how many now, this is an old number, but it's just to show this is when I reached around 40 of these tuberculum meningiomas, the gross total resection, almost 90% on these cases. The main problems I had was like real lateral extensions when these tumors were a little beyond of tuberculum meningioma, kind of going beyond the carotid, or previous resections as well with scar formation in the area there. But for the most part, for virgin cases with the not so big of tuberculum meningiomas, we in general able to resect those tumors. Like I said, 10% of CSF leak is what we tell the patients based on our own numbers. And the main morbidities that I've seen over the years is like accidents or problems with the superior hypophyseal arteries. And that's why we really careful with those and try to identify them very early in the case, you know, and to avoid vision deterioration. So there's most of the time you end up seeing the superior hypophyseal arteries, as you see here, at the end of the case in tuberculum meningiomas, because most of the time this is an anatomy that is pushed posteriorly. But I've seen tuberculum meningiomas that don't touch the diaphragma cellae, where the superior hypophyseal artery actually dive under the tumor to then go up. And that's one case that I had an accident because I didn't realize the anatomy, that variation. And I bipolar the lower part of the tumor when I realized that I actually got the superior hypophyseal running down. So very careful in those cases where the tumor doesn't touch the diaphragma cellae. Most of the time, they are pushed posteriorly, and if you preserve the arachnoid, you're actually able to see them at the end of the case. So these are just examples of some of tuberculum meningiomas that we've done. These are just probably one of my early cases, one of the 10 initial cases showing different flavors. Sometimes most of them actually, if you put in those classifications, they will end up with a 5 or 6 on the score. And this is the MRIs that I important to see the position of the flap, if the flap is enhancing, and if the pituitary gland is enhancing. More recently here, we've been using ICG, and ICG helps some things, like it helps you to define the position of the carotid artery. You can really see where the carotid artery is. For tuberculum meningiomas, also shows you some of the enhancement on the meconial arteries. So here then we use the ICG to bipolar the meconial arteries. This is a small tuberculum meningioma. The patient was losing vision on the left side only. So it was a kind of eccentric tuberculum to the left side. But you can see here that the beauty of doing this endonasal, probably this is a very well selected case where you shows that you don't really need to touch that optic nerve there. And you can see we did an open selected. At the end of the case, you can use the ICG to try to define if there's any residual. Here I'm using the bipolar aquamentis, and you can see the superior hypophyseal artery branches, the optic nerve, you see the carotid exposed. We open very laterally, and this is something that can help you, defining residual and also the blood supply, plus to optimize your opening, defining the position of the carotid arteries as well. Other concerns that people have is the invasion of the optic canal, or when surrounds the carotid like that. And one thing that I like to show, this is a very old video, but shows the we cut the optic canals from medial, and the invasion of this tuberculum cellae meningiomas inside the optic canal can be accessed directly endonasal. Actually easier to do that than coming with a craniotomy, particularly if you're dealing with the ipsilateral. So the optic nerve here, we're not touching it, and we are able to deal with this is the ophthalmic artery, opening very widely there. Very important to remove the bone in this area of the medial optic carotid recess to be able to get all the way laterally there. We're working above the carotid and taking the last piece of meningioma that was in the area there. So post-op, you can see the resection with the stalk preserved, with the pituitary gland preserved. Here's showing the techniques, just to emphasize. Here's another case where you see the optic nerve on the cistern, you see the olfactory nerve up there, and this is a meningioma invading the canal. So you can actually open medially and really decompress this optic nerve coming endonasal in this case. So it's a consideration that I do think that the decompression can be very well done. And because most of the tuberculum cellae meningiomas invade the canal from the medial aspect, the endonasal gives you an excellent advantage by decompressing this, and then we're taking the rest of the tumor there. Then we'll have some of the limits of this. This was a tumor that came in a lady, she was 48, so and functionally blind bilaterally. With this tumor, she didn't know what was happening. And if you look at here, this invades the Sylvian fissure, goes around the MCA here. So I really thought that my plan on this was the first time that I thought about combining approaches. I thought that I would probably debulk this tumor endonasal to decompress the optic nerves, and then possibly later on come, once the optic nerves is more decompressed, then come with a craniotomy. You can see this tumor was going all the way to the basilar artery as well, and encasing the MCA there. So this is a case that by the definition of the study, there is like a number 6 on their classification. And you can see here with a good exposure, the tumor was actually soft. We're able to rotate and bring the tumor from the Sylvian fissure there and decompress the optic nerves. You can see here we found this pituitary stalk inferiorly there. Some areas, some parts of the tumor was soft. So that allowed us to decompress. Not only that, but we were able to use by hand technique, as you can see here, sharp dissection, and get the entire tumor resected. All the way bringing from the Sylvian fissure, you can see the bifurcation of the carotid all the way there, anterior cerebral artery crossing on top of the optic nerves. And here the superior hypophyseal artery being dissected on the right side, and with two-hand technique. And this is the final result. We were able to remove the whole tumor without even touching the optic apparatus. You can see the bifurcation MCA there, that the tumor created that space. We're able actually to roll it back. But the importance here is really the exposure. Like we went from carotid to carotid, so removing the bone, this has to be the most important aspect of being able to do this type of, and I was actually, I remember like yesterday when I went talk to the family, I prepared the family for 2 surgeries, and I got there and I said, hey, turns out I got the whole tumor out and everything went very well. She didn't have any leakage. She didn't have any deterioration of her vision. Over time, she did improve some of her vision to the point that she's able to read a book now. Her vision is far from being normal. It's definitely with a lot of deficit still, but she can read a book, and this has been probably 8-9 years already of surgery with no recurrence. So, and now this is another case that shows very well our philosophy here. This is a tumor that when I studied, I was planning to initially go endonasal, and I looked this carefully, and I noticed that the optic canal was invaded from the top. And this is more like an extension to the anterior clinoid. And as it was invaded from the top, when I went back and forth with the video, it looked like to me that the nerve was pushed down and then going up. So, and with invasion of the canal as well. So when I look at this, I decided to actually come with a craniotomy. I did an eyebrow approach and a subfrontal approach and resect this with an eyebrow. And we were able to get a complete resection of this tumor, you know, following the principles. And indeed, the optic nerve was pushed down, and I was able to open the optic canal from the top and completely resect that tumor. And this patient was very happy with the resection. The other consideration in anterior skull-base meningiomas is olfaction. And this is something I learned from Dr. Schroeder here in the room there. You know, like I had to really pay attention on that over the years. So this is a patient that had normal olfaction, normal smell. And this is one of the ones that I put the patient in risk over like early in my career, because you can see this had hyperostosis, the tumor went up, there's some contact with anterior circulation. So those are all considerations when we are doing planus sphenoidale meningioma now here, and doesn't go into the olfactory area. So this is a tumor that if you do a craniotomy, probably the best option for the patient. I think nowadays I would do that. At that time, this is, I don't know, 10 years ago, I went endonasal and I went up with a 45-degree endoscope. I removed the hyperostosis and I got the whole tumor out, still able to preserve olfaction for the patient. So I'm gonna go up here and you can see it was not an easy surgery. We had to dissect the frontal polar that was going through the tumor. It shows here that a very wide exposure. But my point here that I want to move the video to the point is right in this area. On the right side, we were able to actually protect the olfactory nerve. And we did all this without disrupting the olfactory groove. You see the olfactory nerve up there, we preserve it. And we were able to remove this tumor completely, you know, by preserving the septum, preserving the olfactory area. So it was very difficult to do that. But we were able to. She was 27. You can see the olfactory nerve preserved, going to the olfactory groove, and then we perform reconstruction with the collagen matrix, followed by fat and the flap that we use it at the end. So we like to, in these cases that is anterior skull base, I always put some fat in the sphenoid to help the flap to kind of basically reflect and come more anteriorly in the skull base. So see, you can see here, we preserve the olfactory area, we remove the tumor, some fat in the sphenoid, and the flap kind of going around. So it's amazing because she didn't have any smell by 3 months after surgery, but about 3, 4, 5, 6 months, she came back and her smell was tested and she basically has normal smell. So we were lucky in this case here, got resected with no problem. It's nice when you have somebody like this gentleman that arrived to us without any smell, when we've been testing every patient now to help us to make a decision. The other consideration, no touching on the anterior cerebral artery there. And so this is with some edema. I always look at edema to make a decision. If there's a lot of edema, I prefer coming endonasal because then you don't fight with the brain with the craniotomy. And if I'm decided on a craniotomy, then the edema allows me also to see and try to enter through the side that has less edema. But the beauty is that by coming endonasal on this patient that didn't have smell, we have the flap there. Then you see that afterwards the encephalomalacia, it's minimal or not seen, and the edema improves afterwards with the endonasal approach. So it's something to take in consideration as well. When I see a lot of edema like these cases, I have a tendency to prefer endonasal approach. But then you start seeing these gigantic cases. And early in my career, that's what I want to show the progression of the way I think about them. I actually did this in 2 endonasal stages. And you can see not only that, this surrounds the anterior circulation, goes beyond the optic nerves on both sides, has a lot of hyperostosis and blood supply. So here is the second stage. And in order to take these tumors endonasal, it's very important to find earlier the sella, the pituitary stalk, and the optic chiasm inferiorly and be pushed by the tumor down. So that way you can protect it. And then once you find the anterior, you find the optic nerves, we went around here dissecting. And this is just more to show that it's possible. Once you find the optic nerves, then you look at just above it. And the same way we find it in the craniotomies, we're able to find anterior circulation and follow it up. This is all done endonasal, and you can see here the anterior cerebral arteries, there's tumor going around, and we're able to dissect and peel those vessels. We were lucky here. I just had one problem with the branch of the anterior cerebral artery that I was able to bipolar and coagulate. And then we closed that with Duragene and the fat and the flat, like I showed it before. But here's the deal. The problem with this case I learned with experience is that I was leaving a little bit of tumor on top of the clinoid that I wasn't able to reach and see, because anteriorly you can lateralize the orbit, but as you go more posteriorly, you actually cannot retract the optic canal. So by leaving that there, patient did great, but over time I was following up, and then he started developing growth of that residual there. So basically I didn't solve the problem for this patient. And that's, I recently, I think a year ago, I had to do a craniotomy to take this out. He's doing very well, but I had to complement my resection with a craniotomy. So all those things in mind. So when I see patients like this with a lateral extension on top of the canal, and this patient had a normal smell, so even with some hyperostosis, so now I prefer now to go with the craniotomy on this, because I want to solve the problem for the patient and the edema on the left side. So I decided to come with an eyebrow approach through the right, and this is the result, and full resection and preservation of the smell for this patient coming with a minimum invasive eyebrow. So you really have to look at case by case. This is another patient that came to me with the desire to have the surgery endonasal, because they hear about, they see on the internet, and a little bit of edema there. So if you look at here, the smell was normal for this gentleman. There's no invasion of the olfactory groove on the right side, only on the left. So I decided to come with a craniotomy from the left side, and I prefer unilateral exactly to preserve the olfaction as well. And because of the edemas on the left, in these cases, I actually removed the orbit rim and did a skull-base approach there and got it out and preserved the olfaction on the other side. Ipsilaterally was disease invasion, but we were able to preserve smell with a craniotomy and a complete resection, and his vision that was deterioration got better as well. So then you would think, okay, so why we don't do just craniotomy for these cases? And this is an interesting case that one of my colleagues 10 years before me did a bicoronal and resect this tumor. You see there was some edema around, but he was able to get it out. I saw this in our archives here at Ohio State. He left the institution, and this patient then came back to see me 10 years later. You can see the edema has increased a little more of encephalomalacia, but no stroke. He did a very good job. The problem is that he left the hyperostosis right there. And then 10 years later, when she shows up in my clinic, that's it. Like has recurrence, and with the tuberculum cell component and surrounding vessels here and so on. So at this point, I felt, well, this is a lot of scar there. So I actually decided to come and complement his resection by coming endonasal. And that's what we got here. We were able to get that resected all the way there. She had another meningioma in the falx there that, of course, we're not able to reach all the way past through the brain there. But what was the intention here, of course, we got a good complementation of his original resection. So the reason I like to show this is because this showed to me that some of these tumors may be better dealt with a combination of approaches. So when I see a lot of hyperostosis, I know endonasal is better for that. Endonasal is better for early devascularization, taking the anterior and posterior ethmoidal arteries on these tumors, but endonasal is not good for this lateral extension. So what I start doing is to go endonasal first and plan for 2 stages. I remove this hyperostosis, I take the anterior and posterior ethmoidal arteries, and I convert a very vascularized tumor like this by removing the anterior ethmoidal and posterior ethmoidal arteries, and then I debulk the tumor in the center without trying to remove the tumor completely. I leave that for the second stage. And then what happened, you see this is like a month later, you see the tumor is debulked, the vascularization is gone, And over time, actually, the edema on the brain gets better. So then instead of doing and being worried about the second stage, 2, 3, 4 months later in general, I then come back and I resect it with a small craniotomy and get that out, because now I'm not worried about the reconstruction. The flap is already doing the reconstruction. These are patients that lost the smell 10 years before, 20 years before, sometimes on the story, and then convert 2 surgeries to get as close as it can get to a Simpson one with this strategy. So we've done other cases with this. You can see it goes beyond the optic here. I know I cannot do endonasal. There's hyperostosis. So we did stage 1 endonasal. This patient had lung cancer, and patient decided not to have the second stage, went home. But then he came back a year later, said, Dr. Prevedello, I got cured. You need to take the rest of the tumor. And then a year later, actually, the residual has progressed. And but because I already had done endonasal, then at this point, I just came with an open approach. And here's when I removed the rest of the tumor by coming with a craniotomy. And then then he got a great resection of the tumor there for him. So this is another example. It shows like these tumors can go from frontal sinus all the way pushing the optic apparatus down. This patient was going blind, a lot of edema. So here we use the same strategy, stage 1 endonasal, devascularization, debulking, and then followed by the second surgery. That rarely you will need to use a retractor. You will see that the brain is relaxed, and you can actually dissect the residual tumor with no major problem here. Here's the last part of the craniotomy, where we're coming with a frontolateral approach and resection of this tumor, completing the what, like I said, the closest that it can get from like a Simpson one. I want to show you here the interesting that the flap, it covers up there, and you can actually feel this soft as we come from the top, and the optic canals are open and free of tumor. And this patient, they do very well. So, hopefully COVID will be better. And I would like to invite you all and put in your calendars there for February 12 to, or even 10 to 14 of next year, we'll be in Atlanta. And we're, happy to be coordinating and organizing that again. So thank you so much. And I will be happy to answer any question.
Danny, that was really brilliant. I think excellent talk, like you always do. I would ask Henry, can you see all the questions on the side, or do you want me to ask the questions?
No, I don't see it. Please go ahead.
Okay. So there were a few questions on the way. The first question was, what's your indication for doing a supraorbital endoscopic approach?
So the supraorbital endoscopic approach, what I do, in these cases, to be honest, I do the eyebrow, I do the craniotomy, and I start with the microscope because it's in view. And I start with the microscope, I operate with the microscope, and then I bring the endoscope more to look at under the optic, to look at the end, more of that at the end of the procedure. I don't do purely endoscopic eyebrow in these cases, but I basically bring the endoscope in all cases to make sure that I see under that ipsilateral optic canal. So that's my main indication. Basically, I use it all the time, and mainly to assist to make sure I get a more complete resection. Just last week, I did one that I had to look at under, and for my surprise, is always surprising that you can see more with the endoscope, and then you find more going to the canal. Then I spend more extra time. And then that part of the resection I may do under endoscopic visualization, but not initially where you see everything in view with the microscope. I don't know if Henry has a different opinion with that.
No, I do the same. If you have the ipsilateral optic nerve, it's very difficult to see under it. You always need retraction, and that's why we always use an endoscope. For olfactory groove, you need it because olfactory groove is usually very steep, and you cannot look down with a microscope from an eyebrow. If you have a standard frontolateral, you can easily look down.
That's right.
For both eyebrow approaches, you need an endoscope, in my opinion.
Yeah, I agree. I agree. Same.
So the
same with that.
indication for supraorbital approach versus going through the nose, how would you, which patients you do supraorbitally and which patients you'd come from below?
Yeah, so very good question. For me, it's all about the optic nerve and the optic canal there. If I see even small tumors, if I try to demonstrate in the talk with one example, if there is a disease going superior and lateral implantation that is obvious on the MRI, even in small cases, I don't force endonasal because I know it can first hurt the patient. Second, you may just leave disease there. So I think it is a very meticulous indication to consider one or the other is very important.
And I take it you use navigation in every case.
I do. It facilitates endonasal cases. We use navigation all the time. For the open approaches, we use navigation as well. You know, it's not that you need it all the time, but we always have it there if in cases is needed. You know, it's like Amin Kassam used to say, it's like flying a plane. Sometimes you need the instruments, and you never know when you're going to need the instruments.
Okay. What about, have you got any tricks for CSF leak?
Well, the CSF leak for the most of these anterior skull bases, like I showed you, I use the collagen matrix followed by fat. I think the fat is very helpful. If you try to not use fat in the sphenoid, you're going to regret, and then covering with the flap there. The other thing, the use or not use glue, I think is not relevant. I sometimes use as the last layer, but I don't think is that much important. I know lumbar drain is something that people ask in our practice for our anterior skull base. I never use a lumbar drain during the first surgery. I only use it in case this patient has a leak, come back to the operating room, and then I try to repair, and this patient may leave the operating room with the lumbar drain. But I don't use primarily in my first case.
Okay. Then there's a question about what's your average duration for these surgeries doing endoscopic? Yeah, it's a good question. I think it used to be longer. I think over time we get better, particularly with the approach. The ENTs got better, making flaps much faster as well. So I still, though, if I'm doing an anterior skull base meningioma, I don't schedule any case to follow. You know, it's my case of the day. So I started in the morning, and usually I think we'll be done by mid-afternoon. But I don't schedule anything to follow because, you know, some of these cases, if you get into a vessel or some like complication, then you don't want to have anything to follow. You may end up going all the way to early night or so. It's unlikely to go further. I think I had much longer cases when I tried to remove these giant meningiomas at one stage. But now more often I do this staging, do the endonasal phase, and then they do the craniotomy a few months later. I think it has been, I'm being very happy with that type of technique in terms of doing 2 stages planned for these patients with a lot of giant meningiomas with a lot of edema. So those, if you do a planned stage 1, that stage 1, early afternoon, you're done. Okay, Carlos is asking, is surgery totally bimanual, or do you use holder as well sometimes?
No, yeah, for those that are familiar with our team, like with Ricardo Corral and Brad Otto as ENTs, they basically dynamically hold the endoscope, and they help me a lot as well with the third hand, because they hold the endoscope with one hand. And let's say I have 2 hands, I have a suction in one hand, and I have my dissector. It's similar to some techniques you see for vestibular schwannomas where 2 surgeons, one maybe grab and give a little tension. I asked Brad Otto or Corral, can you give me a little tension on the tumor? So they grab the tumor with one hand and they move a little bit, expose the arachnoid, and then I go with suction, dissection, and scissors. And then having a second surgeon is really, really helpful for the meningiomas of the anterior skull base. Excellent question.
Chandra, you want to ask something?
Yes, Danny, thanks for a very nice talk. And you really showed some wonderful cases. I would like to ask a question which is the recurring theme on anterocranial fossa meningiomas now. People are talking about doing endonasal, and now many people are going away from endonasal. And one of the main reasons is, there are 2 basic reasons, as you are aware. One is the fear of recurrence, of course, which seems to be much higher in others' experience. So now that you have spent more than 12, 13 years doing this, you may be able to tell us if you have analyzed your cases. And the second is better visual recovery. Can you make comments on these two aspects?
Yeah, so a very good question. So in terms of recurrence, tuberculum cell meningiomas, the recurrence that I have to look in detail. The number I'm not going to be able to tell you now, but the recurrence for those, I see my patients, myself as returns, and is minimal. The tuberculum cell meningioma, I think, is what the closest we can get for Simpson 1, particularly the not so big ones. Those are great. Like, you don't see recurrence on those. It's not zero, but is minimal. For the anterior skull base, I think I showed a case example as well, where you see either on top of the clinoids, or I'll tell you, there's another area. The tumor is very, very large. I see a recurrence on the falx, like because it was invading the falx anteriorly, and then I take the whole tumor out, post-op MRI looks clean, and then a little nodules start growing on the falx there. And that's something that I've seen a couple times as well for the olfactory large ones. But I don't think recurrence is a concern in endonasal if you do a well selection of your cases. I think overall you can get a better outcome in terms of avoiding recurrence with a better resection. But again, I think what I've been doing, this technique of 2 stages, I've been doing already for 5 years. So for the last 5 years, if I feel that there is a chance that there's a tail laterally, I already tell the patient, I think the best for you, you're young, is for us to remove completely. Let me go endonasal stage 1 and then stage 2 open. Because if you saw my case there, if you do craniotomy only on these cases, you end up leaving hyperostosis. You fight with the brain,
right.
and you have a bleeding. You have bleeding. So I'm really happy with this technique. I think anyone that changed to that is going to love it, because you transform, for the patient, it's 2 surgeries, but they are 2 like less involved surgeries, because when you go in the nasal, you're not dissecting in between brain and tumor. You basically, it's a very easy surgery. Once you make a nice debulking of the tumor, you're done. You just cover with the flap. And then when you come back, the brain is more relaxed, the edema got better, the tumor, as you saw, like it collapses, and there's less flare changes on the brain. So this is why I wait 3-4 months, because my experience is that's what it takes for the flare to go away. And then you take the second surgery, you reach as close as then to what we can for a Simpson 1. And here's the reason not to dissect between the brain and the tumor is because you form scar. I learned the bad way. I have one case that I try, maybe this will come out. And I start manipulating the brain there. When I came back and with the craniotomy a couple months later, that area was very difficult to resect. I had PIA invasion, and there was a vessel there. I had to spend an hour to dissect, versus the case that is completely feels virgin when you come back, that if you never touch that interface, then you will be much happier. So now I don't even look. I try not to see brain in the first stage. Really try to just debulk and take it out and decompress, and then the second surgery to remove completely.
That's brilliant.
So is your percentage of...
Sorry, Luigi says, nice job, Danny.
Thank you.
Sorry,
your
carry on,
number of
Chandra.
combined cases is increasing, you think?
Say it again, I'm sorry.
Your cases of combined approach or 2-stage approach are increasing over a period of time?
I still, let's say, if I see a large meningioma that has a narrow base, and I had one recently, narrow base, it's large and tall, doesn't touch the anterior circulation, the smell is gone, I still go endonasal and take it out in 1 stage. You see?
Okay.
So it's really, I pick the cases, and I think that's what the secret is. And then let me tell you, then I see a small tumor on the planum, and the patient has normal smell. I do an eyebrow and take it out. You know what I mean? So then the smell is preserved, and I don't think. I hear like you guys, a lot of surgeons went away from endonasal, are not doing anymore. I think I just learned over the years what is better for the patient, the cases that is better to do one way or the other. So I still do endonasal a good amount. And then there's the ones I do craniotomy only, like lateral extensions and considerations on olfaction. And the ones that I do the 2 stages when they are gigantic with a lot of edema and no smell there. So my number of meningiomas done endonasal maybe decrease a little bit, but I still do them quite a bit.
Okay,
Great.
there's a
Thanks,
question from Suresh. He's asking, do you prefer to open the optic canal endonasally in the beginning to avoid traction on the optic apparatus during tumor dissection?
Yeah, that's a concept that I do for open approaches on the falciform ligament. The first thing I do is to open the falciform ligament when I do craniotomy. When I go endonasal, I don't do that. I start in the middle, I debulk, and I leave the canals for the end. I think it's easier because then I find the optic nerves deeply and I follow them into the canal. And then I open the canal and I track to see if there's more tumor. The difference is because when you go endonasal, it's not a falciform ligament. It's really the dura of the canal. So in my mind is not to decompress during surgery because you're from inside out to the resection, you start in the center. Is really to make sure that I got a complete resection at the end.
Okay, Vinod is asking the second stage, can you do it after a few days if everything settles down instead of waiting months?
The problem with that is I don't know what is the exact amount of time. Okay, so I use the concern I have is the healing of the flap, because I don't want to go from the top and disrupt the flap and cause a leak, right? Remember, it's all fresh. So the shortest that I've done is 2 months. The reason I did in 2 months is because I felt that I left and ended up leaving too much of on top of the optic nerve posteriorly. And the patient had vision loss that did not get better with my endonasal case. So I waited, I waited, I felt that maybe it's getting better, patient was getting a little bit better, but the deficit was still too much. And I was disappointed. And nowadays, that's one thing that is very important to me, is to optimize the decompression, really kind of debulk that tumor and to avoid that type of scenario. So the shortest period that I did was 2 months. Then this lady I said, I'm not going to wait for 3 months. Let's just do it. Then I did the craniotomy, took it out, and 2 months was perfect. The floor was healed. I don't know if you can do in 6 weeks or 1 month because I've never done. The minimum I've done was 2 months.
Okay, I think we're running short of time. We have time for multiple choice questions that both Pepe and Danny sent to us. So we're going to go to those multiple choice questions, have a look at them. Emad, can you please share the screen? And Henry, do you want to take this away? Would you like to read them through? Henry, can you read them through? You can't read them. Okay, Pepe, could you take them?
Yeah, I can read them. There is in one of my, I just realized that in one of my answers there is a mistake, so I will correct in live.
No problem.
Sorry.
Should I read this?
Yes, please. Go on.
Yeah, so the question here is when you're dealing with tuberculum cellular meningiomas, what is the main blood supply of tuberculum cellular meningioma? Is the anterior ethmoidal artery, posterior ethmoidal arteries, meconal arteries, or the sphenopalatine arteries? So good. Do they have a time?
They have the same form and they're marking on their form as we go along.
Okay.
And so once you go down to the answers,
people sending on the chat, yeah.
Yeah.
Second question, what is the main blood supply now for olfactory groove meningiomas? They can get very large. And is the anterior ethmoidal arteries, posterior ethmoidal arteries, meconal arteries, or you can have all of them?
Okay, move on.
I think like Pepe was saying, I think go back to the number 2. I think of course the size will be
Can we go back to number 2, please?
Yeah, because if you have a small one, I will comment on this. Small one, and I see some people putting A. I guess for a small one, you can have just A. But for the large ones, then you may have all of them. Number 3, endoscopic and nasal approach. I think it's a good question.
Ahmad, can you bring it up?
Is
More? Number 3. We need to go to number 3
now.
please.
Number 3, endoscopic and nasal approach is good indication for a olfactory groove meningioma with normal smell, an anterior clinoid meningioma, a tuberculum celli meningioma with optic canal invasion, or a planus phenodale meningioma with an anterior communicating artery encasement. Which one is a good one for endonasal? Hopefully the lecture helped on this.
We'll find out because we'll be asking them how you taught them.
Yeah.
So let's go down and we go through Pepe's questions.
Okay, these are my questions. The number 1 is, in case of intraventricular tumor or less than 3 centimeters in diameter in a patient without hydrocephalus, that means with a completely normal ventricle, only endoscopic biopsy is feasible. B is complete removal through transcallosal or transcortical approaches indicated. Endoscopic removal is an option in presence of good instrumentation and adequate training. Neuronavigation is never necessary. And B plus C.
Okay. Please, can you go up? Can you go up and make sure they can understand what B plus C means?
B plus C means that both complete removal through transcallosal or transcortical approaches indicated. If you have no endoscope, of course, this is a good option. And the C is endoscopic removal is an option in presence of good instrumentation and adequate training. So B plus C means that both B and C are reasonable depending on the setting you're working in.
Okay. 2.
Okay, 2 is to perform an endoscopic removal of an intraventricular tumors in a patient without hydrocephalus or ventricular dilatation. Neuronavigation is never necessary. Continuous irrigation is useful to keep ventricles dilated. Continuous irrigation is useful to remove blood and debris. Intraoperative monitoring of somatosensory and motor potential is indicated in the B plus D. And of course, here there is a mistake. I'm very sorry. The good answer was B plus C. So there is a mistake, of course, and B plus C, because continuous irrigation is very useful to keep ventricles dilated during the procedure. And of course, is also very useful to remove bloods and debris. Okay. Intraoperative monitoring is basically, in my experience, never indicated for intraventricular tumor surgery.
Okay, good. Let's move up. Number 3.
Number 3. Surgical step of an intraventricular neuroendoscopic procedure associated with the highest rate of permanent neurological injury. Ventricular cannulation, intraventricular irrigation, tumor manipulation and aspiration, septostomy, and venous injury entering the foramen moral. Sometimes you can think that ventricular cannulation is the easiest step.
Yep. And they will have trouble.
In case of third ventricular tumor of less than 1.5 centimeters located at the inlet of the Sylvian aqueduct with mild hydrocephalus, standard precoronal bar hole is indicated for both ATV and tumor biopsy removal. Precoronal bar hole located 2-3 centimeters anterior to coronal is indicated if ATV should be added to tumor biopsy. A very anterior bar hole airline with mandatory use of navigation is indicated if only tumor biopsy or removal is indicated. B plus C are reasonable, and ETV is always sufficient. Tumor biopsy removal is never indicated. And then talking about tuberous sclerosis, in the case of tuberous sclerosis, when we are dealing with SEGA in tuberous sclerosis, surgical removal is always indicated at diagnosis. The only treatment is surgical. Surgery is indicated mainly in case of progression with hydrocephalus. Transcallosal, transcortical approach are the only surgical options, and endoscopic removal is never indicated due to the firm consistence of the SEGA tumor.
Okay, let's have a look at the answers now. Can you go down? Question 1. Danny?
Yeah, so the blood supply for tuberculous meningiomas, most people put it at posterior ethmoidal arteries. And as you can have some branches from posterior ethmoidal arteries, but the reality is like you get meconial arteries. 1/4 of people answer correctly. Is the blood supply that comes directly from the internal capillary arteries of meconial. They come directly from the carotid, and you can actually see them hypertrophic during the tuberculum sellae approach to the anterior skull base. So the answer correct is C.
Okay, go down.
So for this, the olfactory groove meningiomas, the idea is that all these arteries can actually supply those large, giant tuberculum sellae meningiomas as they grow through the entire anterior skull base. You can get anterior, posterior, and meconial arteries blood supply. For the small ones, I think who answered the A, anterior ethmoidal arteries, it's also kind of relatively correct because I didn't think about that. You know, then I think thinking it back. An answer A could be correct as well. And I guess for A and B, the reality is all these three arteries can be part of it. So the most correct is all of above, D.
Okay.
But I understand why people went through the isolated answers. The third question, endoscopic canalized approach is a good indication. And let's go. So 1/3 answer olfactory meningioma with normal smell. It's not a good idea if the smell is normal. I think that was our point that's something that we will do a craniotomy because it's more likely to preserve smell with a craniotomy. So it's not a good indication for endonasal. B, anterior clinar meningioma, they are lateral to the optic nerve, so it's not a good indication for optic anterior clinar meningioma. And the good answer is the tuberculum sellae meningioma. Most people, almost 2/3 basically got it right. Because even if there's optic canal invasion, you can actually open up, as we showed, and clean the optic canal immediately. And the plano meningioma with the ACOM encasement, it's more like of a challenge case. Most people will be more comfortable doing that with a craniotomy where you can follow the vessels going into the tumor. So it's not a great indication, D. So most people did very well on this one.
Okay, 4th. So we have
Pepe.
Yeah, Pepe.
Yes. In case of intraventricular tumor, 3 centimeters in diameter, a patient without so most of people answer B plus C. It is quite clear that depending on the setting, I mean, I explained already, because only endoscopic biopsy is feasible is clearly false. There are many things you can do with kind of tumor. A complete removal through a transcallosal, transcortical, depending on your preferences. I prefer transcallosal. Never do transcortical anymore in intraventricular tumor of the anterior 2/3 of the ventricles, and so it is absolutely a feasible option if you don't have endoscopic or if you don't like endoscopic procedure. And sorry, can you remain on 1, please? Sorry.
Go back.
Can you go back on 1? Endoscopic removal is an option if you have a good instrumentation, adequate training. I have shown that with a good ultrasonic aspirator, this is feasible. And then it is covered by I mean, biopsy is never necessary. This is not true because no navigation is never necessary. This is not true. I always do when in the absence of hydrocephalus, I always use navigation, and I would consider it mandatory if you have a navigation available in your department. So let's go to number 2. So B plus C is correct. To perform an endoscopic removal of an intraventricular tumor in a patient without hydrocephalus, the proper answer, I say that continuous irrigation, B and C, is valid. So B plus C, because continuous irrigation is very important, is mandatory to keep the ventricles dilated, to replace the fluid that you are aspirating to remove blood and red. So B plus C is a good answer. Sorry, there was a mistake from my side, sorry. So number 3. Surgical step of an intraventricular endoscopic procedure associated with the highest rate of permanent neurological injury, in my experience, is the ventricular cannulation. Is not venous injury entering the foramen of Monroe. Ventricular cannulation is a very underreported complication in the world and even in the literature. But when you look at personal experience of everybody, there is always some ventricular cannulation going wrong when not using the neuronavigation. The risk of thalamic injury or capsular injury or even vascular injury is incredibly important when you don't use the navigation, and especially in a normal size ventricle or in mild hydrocephalus. So be very careful about ventricular cannulation. When you are, many people answer E, this is the second in your line. But normally when you are working into the foramen Monro, people is extremely careful and work in a very, very careful way. Whereas sometimes when you are doing the blind procedure without navigation of ventricular cannulation, you are too much self-confident and you risk to injury the thalamus or the internal capsule. So be very careful in ventricular cannulation.
Okay,
next answer.
Fourth, please.
Okay, here that was related to pineal tumor. I had no time to talk very much of pineal tumor, but certainly the A is a standard precoronal bar hole is indicated for both ETV and tumor biopsy removal. This is clearly wrong because you cannot do a standard precoronal, because otherwise in a posterior third ventricle you are in troubles. So instead of precoronal bar hole between 2 and 3 centimeters anterior to coronal is indicated if you want to do both ETV and tumor biopsy, so it's a good answer. See a very anterior bar hole in the hairline with the mandatory use of navigation is indicated if you only want to deal with the tumor in the posterior third, so this is also a good answer. So B plus C is certainly true. And the final ETV is always sufficient and tumor biopsy removal is never indicated. Of course, this is not true. In most of the tumor of the posterior third, histology is very, very important. So 5, when dealing with a giant subependymal giant cell astrocytoma, surgical removal is always indicated at diagnosis. This is not true because very frequently this tumor can remain silent for many, many years. If there is no hydrocephalus and they remain asymptomatic, you can delay your surgical treatment. The only treatment is surgical. This is also not true because you also know that you have mTOR inhibitors that are very effective in this kind of tumors. But surgery is indicated mainly in case of progression with hydrocephalus. Most of people answer properly to this question, and this is certainly true. Transcallosal, transcortical approach are the only surgical options. This is not true because you can remove them endoscopically. And endoscopic removal is never indicated in case of SEGA. This is not true because I have shown a few cases of SEGA nicely removed. So most of the people answer properly.
Okay, let's go down. Presenters' feedback. So whose feedback is this, Imad? Do we know it's for both or what?
Yeah, this is of Professor Denny.
Okay, this is Danny Prevedello. So we can see excellent, 74%, and good is 24. A couple of people were okay with your presentation. Go next. Quality of content, again, same. Excellent and good. Excellent 80 plus and good 15%. Go on, next. Rate overall presentation, again, excellent 80 and 20% is good. Well done. Would you like to hear this presenter again? And there are 2 people who said no. I think it's Henry and Pepe who said no.
Absolute correct.
Absolutely. I said no for myself.
So great job, Jenny. Very, very good presentation. So let's go to Pepe. Is this Pepe's, Imad?
Yes, sir.
Okay, so Pepe again got 80% quality of evidence and about 20% is good. And 3 people who are sitting in there said, no, you're not good. Let's go back. Let's go down. What else? Rate of quality, again, same. Rate of overall presentation, 80 plus, excellent, and 16, good. And again, we had a couple of people who are sitting up there who said, they wouldn't like to hear you again. But I think overall, excellent presentation and good feedback. This was all very good. Any comments from Chandra before we go?
I can make a comment.
Yeah, go on.
I want to thank both speakers for the outstanding presentations. Of course, we can discuss a lot about indication for endoscopy for olfactory groove, Danny. That will take another hour.
Right.
But in general, I like it very much that you took your time to join us. I am very happy that the webinars are so well accepted in the neurosurgery community. And of course, we will continue with that. And also want to thank Salman for organizing it in this perfect way. Thank you for everybody, and I wish you a nice weekend.
Thank you,
Thank
Salman.
you.
Thank you so
Thank
much.
I
Thank you,
echo
everyone.
Henry's sentiments.
Okay, so
Nothing more
tomorrow
to add, really. Thanks.
Okay, great. Thank you. Thank you, Danny. Thank you, Pepe. Tomorrow we have Francisco from Milan, who's going to be talking about management of thoracolumbar fractures. And along with him, Greg Trost from Wisconsin is going to discuss cases. On Monday, we have Danny again, and we are talking about tips and tricks of pituitary surgery. With him, we have Amjad Shah from Coventry, who's going to be discussing a case and moderate the session as well. On Wednesday, we have Walter Jeans from George Washington, who's going to be talking about approaching skull-based surgery. Moderator is again from Medicine, Azam, who's a skull-based surgeon from there. So it's going to be fun again. And I think on Friday, we have John Lee, who's going to be talking about endoscopic posterior fossa CP angle tumor removal. So we have the whole week filled up with lots of interesting talks. So all are most welcome, and we'll join again. And we are meeting with IFNE WFNS Endoscopy Committee in 2 weeks for another webinar, which we will post on all these sites and on all our websites. Thank you, everybody. It was a pleasure having you all. Thank you, presenters.
Thank
Thank you.
Excellent.
Appreciate it. I'll see
Thank
you
you,
on
Sam.
Monday.
Thank you.
Thanks,